started, and welcome everyone to our Research Day event for MILI's MBA research. Back in March of 2020, when we were all facing the pandemic, we as the MILI community gathered together and decided on different ways where we can help be part of the solution to the pandemic. And one of the ways we wanted to do that is through finding a way to fund and do some research studies that were timely and that were relevant to COVID-19. And we have funded several research projects so far. And we are so happy to gather together for two other research projects that were conducted recently and over the summer. You will hear from the researchers and the students and their mentors, and I will introduce them very briefly, and then we will go into hearing about what they did. So the first project is called Exploring In-Home Blood Testing for Cancer Screening and How COVID-19 Affected the Future Outlook by Dan Quay Pham, James Ekman, and Sean Clasby, and their mentor and advisor is Dane Stimmert, who's an MBA and the Global Upstream Marketing Manager at Medtronic. As significant attention is given to COVID-19, non-emergent health services such as cancer screening are going unnoticed. As a result, patients initially diagnosed post-pandemic are more likely to be diagnosed with later stage cancers. More patients are opting for in-home blood tests to minimize risks of COVID-19 exposure, while advances in technology allow providers to extract more information from blood samples. This research project sought to determine the landscape of cancer screening before and during pandemic to identify the barriers to cancer screening and how to shape a more effective measure for cancer screening post-pandemic in the United States. As presenters, you will hear from Dan Quay Pham, MILI Fellow and MBA candidate of 2022, co-founder and CEO at Oncodea Cancer Research Lab, and Dan has 7+ years of experience in logistics, marketing, and business management. The second presenter is James Ekman, who has 9 years experience at Fairview Health Services across treasury, corporate and capital and business consulting. He has 3+ years managing finances for Minneapolis Heart Institute and currently the cardiovascular service line at Allina Health. And very special, he is new first-time father to 5-week-old June Lily Ekman. Congratulations, James and family. The third presenter is Sean Clasby, a MILI MBA candidate graduating in spring of 2022. He's a career transitioner interested in medical industry strategy and finance, and he's currently an active CPA with 10 years public and private finance experience. We're looking forward to hearing about your project. The floor is yours.
All right, thank you, Pranav. Can you see my screen?
Yes, we see the screen, but it's not on presentation mode. If you wanted to put it on presentation mode, that may be perfect. Thank you.
Thank you for the introduction. And we want to go straight into the presentation. We have a lot of material I'd like to cover. Cancer is an important disease, as 1 in every 2 or 3 of us will develop cancer at some point in our lifetime. And the current screening methods for cancer pose various challenges, and it becomes clearer during COVID-19. When we look at the current healthcare landscape, we focus our project on 2 main issues that were exacerbated by the pandemic: the ease of access for rural patients and the improvements that can be made in cancer screenings. Without a formal product review, we choose to look at 2 types of products to address these issues: at-home blood sampling devices and AI machine learning to augment predictive analytics. Our conclusion for this project is that we are skeptical that at-home blood testing will be able to overcome its significant hurdles to make an impact in the market. And that AI, while the specifics are still being developed, has significant potential to improve cancer screening, though unlikely to be a standalone diagnostic tool. Our agenda today, we will go from problem and opportunity, COVID-19 and cancer screening, AI potential for screening and biomarkers, at-home sampling. Then we move on to the full picture and conclusion. We would be remiss if we didn't mention Theranos in this presentation. Theranos claimed to have devised Blood tests that require a microscopic amount of blood could be performed very rapidly for a small price. These claims were later proven to be widely false. The facts of the matter is that the ethics and what they wanted to do did not align. You can't do 240 screening tests ranging from cholesterol to cancer with a drop of blood. You can't do science by cherry picking only the results that work for your theory and sciencing the true science itself. The Theranos scandal is creating media hurdles and setting back the adoption for similar technologies. However, it is the wave of the future, where the underlying theories and technologies still hold significant potential to drive efficiencies and solve access hurdles in our healthcare system. Due to consolidation and care facility closures, the distance between rural patients and care facilities has been increasing. This disparity in access is further demonstrated when looking at the map of the US, broken out by counties with healthcare professional shortages. These issues result in less care being provided and worsening health of rural populations. At-home blood sampling, like this Tesla device, could bridge this gap by utilizing telemedicine and postal services to increase utilization telemedicine and postal service to increase access to rural populations. When looking at the economics of cancer diagnosis, we wanted to look at the states of typical detection and compare that to the effects on survival rates. The first graph on the left shows the percentage breakdown of the stages of diagnosis compared with the total number of diagnoses for each cancer type. When we compare these cancers to their 5-year survival rates, the obvious conclusion is that the earlier the detection, the higher the survival rate. When COVID hit, people were very reluctant to go into medical centers with the idea that medical center would put them at risk for exposure. Medical centers are pretty safe now, and people are going back for preventative care. However, it is still inconvenient to have to go into the medical center for screening. Certainly, when we think about even just getting COVID vaccinations out, if we only did it at medical clinics, we probably never get it done, just because it's not convenient for most people. That's why vaccination is being done at convention centers, drugstores, and state fairgrounds. Screening tests could be decentralized and would be better, even in non-COVID times. During the pandemic, sometimes we read in the news that maybe people are going to die needlessly because their cancer wasn't caught. That could be true. However, cancer generally doesn't move quite that fast. Most importantly, COVID-19 shows us clearer picture of the healthcare disparities in community of lower income, less educated, people of color. So we need to do something to address some of that problems. The leading market for cancer diagnostics is liquid biopsy. It is projected to grow at 51% to reach near $14 billion in 2025. Artificial intelligence used for diagnostic of cancer, primarily to detect the early stage of this disease. The market for AI in this segment is estimated to generate global revenues of $3.2 billion in 5 years. That is a growth rate of 48.2%. Historically, blood tests haven't been the best way to detect cancer. However, there is a growing interest in trying to understand whether or not blood work can determine cancer screening risk. At the leading edge in this effort is GREL. They are developing a liquid biopsy test that analyzes DNA methylation in circulating tumor DNA to determine the tissue of origin. Then we have Guardant Health develops Guardant 360 test, provides treatment guidance during the course of a cancer. Then we have Orforma. Genomic sequencing tries to identify benign thyroid nodules, allowing patients to avoid unnecessary surgery. Then Freenome and Gene System measure a panel of protein biomarkers and incorporate machine learning to improve the performance of the biomarker testing. GREL's technology is the leading example of how blood biopsy and machine learning are revolutionizing cancer care. When we talk about cancer tests, we want to look at two things: sensitivity and specificity. Sensitivity refers to a test's ability to put positive cases correctly in a positive box. We like the sensitivity to be reasonably high because we don't want to miss cancer and give people a false sense of security that they don't have the disease. For instance, we can see here for prostate cancer has a sensitivity of 11.2%. That means 88% of people with the disease would go undetected. The specificity value of a test is its ability to put negative cases correctly in the negative box. It may not be useful to use a test with low specificity for screening, since many people without the disease will be screened as positive and potentially receive unnecessary invasive diagnosis and treatment procedures. So what is AI exactly? AI is a term used to describe the creation of machine aiming at reproducing human intelligence through the steps of learning, reasoning, and self-correcting that eventually solve problems and make decisions. Machine learning is a branch of AI that uses algorithms, aka commands to the computers, and statistics to recognize and identify patterns in big data. AI is contributing a useful tool to the health management of cancer. The benefits include shorter diagnosis time, better accuracy, and disease management. However, the utilization of AI in cancer is challenging due to medical data being complex and also containing background noises, which cannot be easily removed. The hype cycle shown here illustrates the AI and machine learning for diagnostics tailored at healthcare providers. The AI technology in question relates closest to AI-enabled diagnostics imaging interpretation, highlighted in yellow. This technology is early in its development and need to reach the plateau of productivity, highlighted in green, before widespread adoption. The estimated timeframe to reach this plateau is 5 to 10 years. Blood is routinely used for testing as they contain rich sources of information that are useful for cancer diagnostics. For the most part, cancer shred proteins into the bloodstream. There are molecular patterns associated with each type of cancer-specific signals generated by biomarkers from cancer and non-cancer cells in response to developing cancer. And each cancer stage generates specific structural-based biomarkers. AI is being taught to recognize the patterns and compositions. These complex interactions include protein complexes, circulate cell-free DNA, RNA, carbohydrates, cellular metabolites, soluble or packed inside exosomes, for example. These patterns and interaction are too complicated and too complex to be analyzed manually, and AI is employed to look for the needle in the haystack.
So what's a biomarker and where are they found? A biomarker is a molecule found in blood, like proteins or leukocytes, that can be measured accurately and reproducibly. About 55% of our blood is plasma, 41% is red blood cells, and 4% are white blood cells and platelets that are suspended in the plasma after the whole blood is centrifuged. Blood components like serum and plasma contain the biomarkers, which AI uses as a rich source of information to identify patterns of disease, like cancer. Blood is sourced from veins, arteries, or a capillary skin puncture and is typically drawn into healthcare facilities. Capillary blood collections occur when sampling blood from a puncture on the finger, heel, or an earlobe and are increasingly common in medicine. Capillary collection employs several advantages over blood from veins or arteries. First, it's less invasive. It also requires smaller volume of blood, and it can be performed quickly and easily by non-clinicians, but it cannot be used for all lab tests. The most common self-capillary blood test today is the blood glucose test for diabetics, but many other tests have been increasing in use and prevalence, especially with the widespread use of point-of-care testing, which has become a fast-growing area of lab medicine. Next slide, please. Here are some technologies using capillary blood collection today. Dried blood spot, or DBS, volumetric absorptive microsampling, or VAMS, point-of-care testing, and numerous field collection devices from various companies. DBS testing is a form of biosampling where blood samples are blotted and dried on filter paper. The dried samples can be easily shipped to a lab and analyzed using various methods. VAMS is a recent microsampling technique used to obtain a fixed volume of dried blood. There are many field collection device companies that offer various products to remotely collect dried blood spots or even whole blood samples with additives. Lastly, Point of care testing are tests that can be performed at or near the point of care rapidly with portable equipment and test kits, and have been increasingly common in the last 20 years. The two major hurdles facing these technologies are logistics and the hematocrit effect. Blood samples degrade over time, and the many sampling methods and disparate products create a complex environment with various restrictions on shipping time, temperatures, and handling protocols. These attributes can drive up overall costs significantly, costs which health systems are not willing to assume without a fight. Our voice of customer research did indicate some appetite for end users to pay for additional postage fees, though. The hematocrit effect is one of the largest hurdles preventing widespread adoption of DBS. Hematocrit issue can affect the accuracy and interpretation of DBS results. Computational solutions are available, but at an intensive cost. Logistical issues and the hematocrit effect provide hurdles that must be overcome before sampling can be extensively relied upon for a wider range of blood tests. This technology matrix compares the various technologies with the most notable attribute that DBS, BAMs, and field collection devices enable self-sampling by non-clinicians or laypersons with varying degrees of ease. Point-of-care testing, requiring potentially expensive equipment but supplying results instantly, is most often encountered within healthcare facilities. DBS has been around the longest and is the cheapest, but enables limited analysis due to extraction, card punching, and it's also impacted by the hematocrit effect. The greatest advantage of VAMs over DBS is VAMs enables a precise and accurate collection of blood volumes for quantitative bioanalysis and automation, while effectively eliminating the hematocrit effect. VAMs is relatively novel though, so some aspects still need to be investigated in depth, but VAMs is increasingly recognized as a viable alternative to DBS and other dried microsampling techniques. Lastly, field collection devices come in many forms from many different manufacturers. These are novel, sometimes research devices, which collect either dried or whole blood with disposable single-use devices. A few of these simplify the blood collection process with the push of a button, which we'll explore in the next slide. 7Sense Biosystems with the tap and tap 2 and TASA with the button both offer products that a user places on their upper arm, presses a button, and 3 to 5 minutes later, the device captures a volume of whole blood. 7Sense uses microneedles to capture over 100 microliters of blood, while TASO uses 4 lancets to capture up to 600 microliters. Spot On Science's HemaSpot product and DBS system Hemaxis are examples of DBS products that collect blood using a lancet finger prick and filter paper. In my hand is the HemaSpot SE device, which includes a spiral-shaped filtering membrane that separates blood components using lateral flow. At a lab, DBSs are then punched from a card in order to be analyzed. The VAMS device, Neoteryx Mitra cartridge, is shown in purple at the bottom right. It captures blood through a finger prick into a device that includes a plastic handle and a globus tip with a diameter of about 4 millimeters. This tip wicks a fixed volume of blood into its pores, 10, 20, or 30 microliter according to tip size. Then the VAMS device is left to dry and is ready to be used for analytical purposes. VAMS devices, after sampling, can enable automation and workflow integration. Next slide. There are, of course, many forms of competition in the market, but the largest threat comes from other testing substitutes like DNA, tissue, saliva, or even others. The largest volume of at-home blood tests today are blood glucose tests for diabetics, but a replacement, the continuous glucose monitor, uses interstitial fluid, not blood, and is upending that market. There are also home blood draw services where clinicians come to patients to draw blood in their home with home healthcare providers, or even large trucks with mobile phlebotomy services from the likes of Quest. Lately, there's also been a proliferation of commercial mail-in tests, which are primarily wellness tests from companies like Everlywell and many others, but they are offering more and more tests, including blood, every day. According to Research and Markets, the North American blood testing market will grow to nearly $23 billion in 2027, a 2.3% CAGR, while the global market will grow at 6.6% to $85 billion by 2027. Next. The largest driver of the blood testing market includes disease incidence and concerns like COVID, aging population, and an increase in screening and earlier detection of maladies. Challenges include testing alternatives, primarily saliva, as well as the cost of equipment and new technology. The largest overall opportunity is for innovative solutions that enable faster, cheaper, and more accurate diagnosis by employing blood screening methods through new technologies and/or AI and machine learning.
On this slide, we wanted to illustrate what this new testing and diagnostic ecosystem could look like. Following the numbers, we would start with the hospital referring the patient for a blood test. The manufacturer would distribute the at-home blood sampling device directly to the patients, who would ship the completed samples back to the lab for testing. Once the lab tests the samples, they would submit the data into the AI algorithm for cancer screening before wrapping the physical lab tests and AI testing together for reimbursement. Next slide, please. With regards to at-home blood sampling, there are two pathways for regulation, either through the in vitro diagnostic route or through the lab-developed test route. IVDs are regulated by the FDA, while LTDs are integrated tests regulated by the administering lab. The regulatory pathway is driven by the end user of the device. When looking at the AI side, the FDA has proposed a regulatory framework to evaluate and monitor changing AI machine learning algorithms based on a pre-market review of the original algorithm and pathways for the algorithm to be improved or adjusted as long as it follows a predetermined modification process. Next slide, please. Reimbursement for blood testing is done based on the clinical lab schedules issued annually by CMS. These tests are established reimbursement pathways that would not be affected by at-home sampling. When we look at the reimbursement landscape for the AI machine learning technology, it is currently being reimbursed as a new technology add-on payment, which limits reimbursement to 85% of costs. This is not a long-term option for reimbursement, and a more permanent reimbursement pathway must be established before widespread adoption. Next slide, please. We surveyed 765 patients, asking a variety of questions related to at-home sampling and openness to cancer screenings. While there were multiple interesting findings, the one we want to focus on is the disparity between participants that are open to cancer screening, the first chart, and participants that are open to at-home sampling, the second chart. We see a steep decrease from 47% down to 26%, illustrating that there is a significant hesitancy from the participant's perspective to participate in at-home sampling. Additionally, elaborated comments from some participants echoed these sentiments about reliability and accuracy. Participants wanted these types of tests to be performed with their physician and were not willing to accept the extra work for the added convenience. These opinions were uniform across the various tested demographics. Next slide, please. We performed 24 interviews with key opinion leaders to gain an unbiased and objective perspective from experts in the field in order to understand the landscape of cancer screening at the present time, how they would envision the future of at-home blood sampling for cancer screening, and what that means for patients. Despite being performed independently, there were three primary themes that arose through the interviews. First, there is an access problem to preventative care for patients, and remote blood tests pose a promising possibility to bridge that gap. Second, the problem with these new tests is there are minimal guidelines and regulations leading to confusion from physicians on how to interpret the results. And third, clarity and consistency in testing output will be needed before the test can be used to augment a physician's diagnosis. Overall, the support for in-home cancer screening tests among the experts are largely positive. If it works, at-home blood sampling can be the wave of the future and lead to an improved cancer screening system. It can bridge the access gap and improve patients' quality of life. However, cancer is a complicated disease, and prediction accuracy is massively important, as over and underdiagnosis poses enormous risk. A meaningful screening test should have 100% sensitivity and specificity, but compared to what we have now, 80% would be a great improvement. Next slide, please. In conclusion, at-home blood testing has the potential to increase access to disenfranchised populations and increase preventative testing, but lacks demand from patients, and widespread adoption is stalled by logistics and sampling limitations. AI machine learning has significant potential to alter long-term standards of care, but widespread adoption will require overcoming regulatory ambiguity, long-term reimbursement uncertainties, and overcoming black box outputs. In order for these two technologies to reach widespread adoption, they must reach the following milestones. First, patients must be educated on the advantages of preventative screenings in order to shift the opinion away from a need-based mindset. Second, AI machine learning must develop a way to compare products and outputs to ensure safety and efficacy. And third, AI machine learning must find a way to provide additional transparency as to how the outputs are determined. And that concludes our presentation. Are there any questions?
Thank you so much. Yeah, if there are any questions, if you could please type in the chat. But as we wait, I would like to see if the project mentor advisor, Dane Stimor, would say a few words about his experience working with the student team, please.
Hey, yeah, and congratulations, guys. The last draft I saw was a lot more content. I was very impressed with this version. You guys did a really good job of shrinking it down. You know, I've been working with this team since the beginning of this year. It was a spring semester group, and gosh, the content out there for this is so overwhelming. And I was actually impressed that you guys brought the Theranos up front, right? Because I think everyone levitates towards that example. It's in the mainstream Hollywood video, and ironically, now it's in court, I think, basically this week or in the coming days. But this is such an incredible area to be in, and to see the detailed analysis that this group did and the way they broke it down, incredibly interesting with the experiences that they have and how they brought this together, and it really separated the AI component from the sampling component. So, you know, I think as we all know, healthcare has changed a lot in the last year, and this could not be more relevant. I know of personal family members, colleagues that have been subjected to waiting on their treatment for cancer specifically because they didn't go into the hospital. And so had this system been more prepared and ready for at home or quick rapid blood testing, likely some of those scenarios could have been caught. So I'm just very impressed with this group, very impressed with this final result, and very interested in this space of industry and where it's going to go. I think this is without question going to be in the forefront of medical innovation.
No, thank you, Dane, and thank you so much for all your effort in mentoring the student team. Really, our alumni is instrumental in this role, working with our students. So thank you for that. In the chat, I see Susan Alpert saying would like to comment on the team. Because of the webinar format, I believe Susan is not able to speak directly. But I think she probably means compliment the team. Really great team. Thank you. I actually wanted to ask if one of the team members could tell us a little bit about how you came up with the question and how you sort of built this team to work on it.
Well,
And you want to jump on that one?
yeah, sure. I mean, so I started a company with my husband 3 years ago, and I literally have no experience in this medical industry. And later on, when we have progress in the technology, it looks like I need to jump in and help with the commercialization, which I have zero experience in. So I would like to learn, and I joined the MBA program at the Carlson. And when I see an opportunity to learn about it, which I've been investing a lot of time and money in, but I have literally no knowledge in. So this is all actually the questions that I would like to answer. And the project offered opportunity to learn that. And I have a very awesome team with me to help me. I know I've been distracted a lot of time, and they help all of us together to go, you know, into the one direction. Has been a great experience.
Great. I see a comment from Eli Berbari, whom I know is the chair of the infectious disease department at Mayo Clinic and one of our executive MBA students. And Eli says, congrats, I'm impressed and agree this is the future of medicine. What is the next step?
I can jump on that one. As part of the conclusion, one of the main things we saw based on our VOC was that there's just not a demand from the patient side for at-home testing. And one of the things we just didn't have time to go into was more the reasoning behind why they didn't want to. A lot of people that we had comment mentioned that they weren't sick and they didn't feel the need to go in for preventative medicine. So we believe for the blood side, one of the big things is, you know, emphasizing preventative medicine, teaching people that going in for routine screenings and getting these things is going to be better for their long-term health because it can identify things like cancers at an earlier stage. Obviously, people don't want to hear bad news, so it kind of dissuades them. But we believe from that side, it's really important to get people to, buy into, tackling things before they're a bigger issue. And from the AI side, it's still an early technology. Yes, there are things that are rolling out into the market right now, but the full widespread adoption, the regulatory and reimbursement side are big. Without a solid framework from the FDA, they're not going to know how they're going to have to go about their regulatory pathway. And the reimbursement currently at 65% of costs up to a certain amount determined one AI to another. We believe there needs to be something in place where you can get more AI to the market faster, and they're not going to have to establish their own pathway individually. So we believe those are the next big steps.
Thank you, Sean. One comment from Susan Alpert. The team reached out to learn about regulation and healthcare discrepancies, which are more visible today than they have been in the past. Making this visible as a tool will make a difference. Then I have one question, actually 2 questions. Maybe I'm going to read them both for the sake of time. If you could maybe answer them both together. One of them is sort of asking about, did you look at different areas for at-home testing outside of cancer, such as monitoring diabetes and hypertension? So that's one. The second one is that the FDA is working to develop requirements for AI. One of the challenges is establishing that the algorithm works correctly in all cases. Do you have any insights on how verification and validation of AI algorithms will be managed? Sorry, I put 2 questions, 2 big questions, but both great questions.
I'll address that second one. So there is a draft legislation trying to clarify how AI and ML are regulated essentially. Right now, they're really one-off PMAs. So in our paper, we went into great detail about how they aim to kind of set the guidelines in basically high and low risk scenarios. Dan, do you want to comment about?
Yes, I could add, kind of a first question is that in the surveys that we did in the university community, overwhelmingly, a lot of people, they don't care about cancer. More like STD or other type of diseases could be done at home instead of going into the lab. And right now, the market, we have a lot of lab developed tests doing just that. And we have elderly well, let's get checked. And the majority of them is that they are being under control clear. And it's just for the lab qualification, but not the test itself. So we see a lot of variation of the one type of test, but they test different components in it. And it's just about, we have to educate ourselves what to look for and be very skeptical with those type of tests and approach them carefully before making any major decision.
Thank you. Thank you so much. Oh,
just to jump on James and Dane's comment, we had so much information on this project, whittling it down for the presentation was tough, but our white paper is just littered with an excess amount of information. So if there are any other questions, we definitely point it that way. And
yes, Kim and I will work on making sure it's shared to the broad community. Thank you so much again. Thank you for doing this work. So we're going to move on to our second presentation, Loon Medical, Eric Zimmer, and Eric's advisor is Marie Johnson, PhD and founder of Loon Medical. The brief description of the project is, as of January 2021, nearly 14% of COVID-19 patients were classified in type 1 respiratory failure, requiring lung imaging to determine damage caused by COVID-19. To address this increased risk during the pandemic, Loon Medical developed a STABI, I hope I'm pronouncing it correctly, or STAB-B, for long-term follow-up assessments to determine if a patient has abnormal lung sounds and should be seen in clinic. To support these efforts, Eric Zimmer developed a novel business and financial model that will offer healthcare and social impact benefits. A little bit of Eric. Eric works for United Health Group while pursuing his Carlson MBA, and he recently moved to North Carolina, where he's living the Southern life with his girlfriend and lab puppy. Thank you, Eric. Floor is yours.
Yeah, hi. Let me share my screen here quick. I just want to give a shout out to the previous group. Your research was absolutely impressive. A little over my head, but yeah, it was crazy. But okay, so I'm presenting on Stubby, which is a Loon MD product. A little background on me. I guess I went to undergrad at the U as well in health services management, kind of like the undergrad MHA. I'm currently employed by United Health Group, as you said, basically doing due diligence on M&A deals for physician groups. And then once we acquire those groups, acting as like a consulting partner for them, getting them integrated. I guess I worked for Fairview before and then worked in healthcare consulting prior to that. And then there's a picture of my dog, but that's it about me. So background on Loon. So Loon Medical is the parent, Loon MD is the subsidiary, and Stubby is the product. And basically, this was created by Marie as a public benefit corp, otherwise known as a B Corp. If anyone's familiar, a perfect example of a B Corp is Patagonia, where they basically give away like 10% of their profits, or it's something like that. I don't know specifically, but yeah, I guess it's main focus would be self-sustaining, socially focused, looking at all of the stakeholders, not just the shareholders, and then public health impacts in disparate populations for Loon Medical specifically. And then Marie has a vision for creating an evergreen fund for philanthropic ventures, basically. So yeah, ultimately it's a medical device startup with Marie being the founder, and the device is patent pending. And I guess for illustration, this is just like a USB here, but like basically the product is, it's something similar size to this, and you plug it into your phone and put it up to your chest, and it'll basically read the lung sounds, sort of like a stethoscope, but the idea is like you could do it from your home and then send the data to like a healthcare professional, whether that's your nurse or doctor, APC, what have you. So for the use of this product, initially, like we're looking at the long-term impact of COVID-19 and maybe using this to see like how COVID has affected the lungs in the long term. And then also like maybe with asthma, exercise-induced asthma, that is, and then also baby monitoring and reading a baby's lungs and checking for potential issues. But I guess more clinical research is definitely needed for that. And I guess ultimately my task is to build a financial model and assist with the business development for the startup. So as I was saying, like the possible uses, basically COVID-19, it's obviously a respiratory disease. So looking at the lung and seeing how it affects the lungs could be important there, but we're not entirely sure on its applicability. And then also like the long-term effects on that, basically looking for lung irregularities and basically any long-term impacts it might have. And then also with asthma, just collecting lung sounds and wheezing, and then baby monitoring. So this is a potential market that we're kind of, I don't know, curious in, because concerned mothers, like they want to know that their baby's okay. So maybe listening to the lung sounds maybe will save them going into the doctor's office if they're just doing a regular lung checkup. But yeah, I guess that was one of the markets we're looking at. And then also the telemedicine consults. It probably results in better health and more data if someone could do a checkup from their own house. Whether, like, I know a lot of I guess at UHG, like I just see data of like all the no-shows that show up for like primary care visits. So if those no-shows could result in actual checkups from being at home, that could be really beneficial to health and I guess, yeah, monitoring health. And so a little background on Marie, very impressive. She's got a biomedical engineering background. I guess I can leave that to Marie to talk more about later, but essentially she's very, very engineering focused and extremely bright. Like when she talks about the product, I can barely understand her, but yeah, it's just really impressive. So I guess the background on the project. So creating the financial model, this is like a big workbook, essentially looking at, I mean, doing research into like the addressable markets and then tying it all into a model and getting all of the assumptions that go into like creating a business. So we know like the financials of what will likely occur, granted you changing the assumptions. So this all flowed through to the income statement, balance sheet, cash flows, and just showing a financial impact if you change those assumptions. An assumption, for example, could be like the price of the product, the volume of how many are sold, and like employee costs, hourly rates, what have you. So, and with that, we can forecast like when we could start a evergreen fund once we hit profitability, and then also looking into like potential like seed funds. So I don't know if anyone's familiar with the SBIR, STTR. They're basically the government sponsored startup funding. So they do it in like 3 rounds, which is like the first round you get up to like 250,000, and then the second round you can get up to like 750,000, and there's a third round that doesn't include money, but they just help you go like basically go to market. And then you can see a little snapshot of like the addressable market based on the research that I did, and like if we were to capture 0.1% of that market, what that results in for capture. So then with that, I was able to create a possible like the financial projections, and kind of looking at the industry tailwinds. Telemedicine seems to be a good focus because it's both helping the community and has the potential for being like a very large market, especially after COVID, with more people staying home. So that's just a quick snapshot on that. To touch base more on the SBIR and STTR, the main difference between the two is STTR, you have to be basically partnered with a nonprofit research institution. So a good example of that would be the University of Minnesota. And then it's just a grant, and they give you the money. If it works out, good. If it doesn't work out, it's like the government's paying for it. So essentially they're not even taking any equity in it, and the focus is to benefit the public. So it's a really cool program, which Marie is looking to basically get or provide an application for. So so the financial model, here's another quick 2 little snapshots of what it shows. It's just for illustration, and it kind of shows the EBIT as time progresses. Like when we have high employee costs, less than the sales, like obviously we're going to be in the red, but as more sales occur, like it'll fight back to positive and become a profitable company. So yeah, I created a bare bones model originally, and then as more assumptions came in, I just fine-tuned it and became a pretty big model by the end of it. And then did miscellaneous research into the addressable markets, into the government funding, any other funding sources that could be used, and then I guess made like a bunch of graphs that show levels of revenue, OPEX, EBIT, employee headcount, etc. So I guess the final cost final recommendations for the project is to keep costs low for the product, so that everyone can afford it. And it'd be nice if insurance paid for it, so it really wasn't a barrier to get the product. And then I guess with that, like more people can get checkups that maybe they wouldn't have gotten. Like I know that disparate populations see the doctor a lot less than maybe more affluent people do. So I really liked Marie's idea of being a public benefit corp. It really shows like that you're focused on the public and not just the shareholders. And then with that, like the Evergreen Fund, for example, is a really great idea for, I guess, giving back to the community. And I guess one of my recommendations is to have like people that buy the product, like have them choose a fund that they would like the proceeds to go to. It's a philanthropic fund, of like basically where they want to donate their money to. And then I guess it based on our projections, like if somewhere in between 2023 and 2025, depending on sales, like they can start this fund and then start giving back to the community. And then I guess contact healthcare professionals to see what they think about the product and get them to recommend it, like basically show like it's a good idea. So that'll save on marketing costs and then provide usefulness to them. So yeah, any questions?
Okay.
Great. Thank you so much. Well, thank you everyone for joining. You know, it's this pandemic has shifted all of us in so many different directions. And if we as MILI could contribute a little bit to advance science and business and in this craziness, we just are very MILI proud, Carlson proud. So thank you everyone for students and their mentors and the inventors and founders who have brought their projects to us, and students who have worked on them and mentors who advise them. And I also want to acknowledge United Health Foundation, who have generously agreed to allocate some of our funds for these projects. So thank you so much, everyone, for joining us, and see you in our next MILI event. Thank you.
Bye.